in diameter, which is totally different from venuloctasia, which is around 2 millimeter in diameter. And when you have a size of 5 millimeter, now we are going toward a truncal varicosis, which extend toward 1 centimeter. Similar names are the hyphen web, spider veins, and thread veins, and it relates to the Greek language, which means dilatation of the vessel ends. So in telangiectasia, how does it start? It starts by a kind of hypoxia in the limbs due to long standing, initiating angiogenesis and endothelial inflammation. And in the majority of the cases, it is asymptomatic, but may be associated with aching pain, itching, cosmetic disfigurements, in addition to a kind of venous hypertension, sometimes valvular incompetence. And you can figure how telangiectasia on the left-hand side differs from venuloctasia with a different size and also in the depths of the vein in relation to the epidermis. So how it starts by many of the predisposing factors. Most of it starts as a familial trend. In the majority of cases, we will find families and localities like in the Middle East. In the Middle East, in the majority of them, they have telangiectasia and venuloctasia of familial origin. And for our fortunate, because this is a great part we are working on. Increase intra-abdominal pressure, any kind of increased pressure, standing for more than 6 hours per day, lack of exercise, sedentary life, even sitting for a prolonged time is a factor in the development of telangiectasia and venuloctasia. Overweight and constipation, in addition to the hormonal therapy, either as a replacement therapy or as a kind of contraceptive use. Localized trauma due to the direct trauma to the underlying perforator, leading to reflux and development of this problem, or photo damage due to exposure to the sunlight, with the damage to the collagen and the elastic tissue surrounding the intradermal venules, pregnancy, both mechanical and hormonal, and aging, because most of the cases starts at the age of 25 in 23% of the cases, and as the age goes up, it reaches 70% by the age of 70 years. Wearing high heel, because this is a major part, because in these cases the patient is using the gluteal muscles instead of using the calf and the foot muscles. So this causes a stasis, and as I said before, the hypoxia in the intradermal layer induces this kind of a tight wear, also is a responsible factor for the development of this kind of telangiectasia. Going through the history, it starts at the 80s, and it was toxic by that time. All kinds of sclerotherapy was toxic by that time, and as the progress goes, they defined that SCTS, or the sodium tetrahedral sulfate, in the 40s. Compression therapy has been advocated in the 50s. Polydocanol has been introduced in 60s, and the Tizari method for foam sclerotherapy preparation in the 90s. And it all goes through 4 kinds of sclerosants, starting from the hypertonic solutions like hypertonic saline solution or the dextrose, detergent agents like the polydocanol, SCTS, sodium tetrahedral sulfate, and sodium urate and ethanol amine oleate. Chemical irritants like the most common is the glycerin and the polyiodide iodine, and a mixture of solution called the mixed sclerosants. Technique, not major differences, but some used proximal to distal. This means you start in the thigh and goes down to the leg and finally at the ankle, because as we all know, filling of the veins comes from above down. So don't start sclerotherapy from below upward, because refilling will happen, hyperpigmentation will happen, and the patient unsatisfaction will be the last result. So in Tournesig and Fegan, they introduced proximal to distal entire varicosity. What do we mean by entire varicosity? This means a completion of the process at one time. A single session, you got to finish all the sclerotherapy, because this minimizes the incidence of hyperpigmentation and the development of or recurrence of the varicose, but it's a great burden on the professionalists. Also, how we adjust the dose in telangiectasia of 1 millimeter, and it counts on the concentration of the sclerosant in addition to the amount of the sclerosant. So if you are dealing with a 1 millimeter telangiectatic vessels with a concentration of 0.5, so you use half of the amount in milliliters. So if you are using a 0.5%, so you use 0.25 milliliter in a total dose. For reticular veins 1 to 3 millimeter, if you are using 1% concentration, you use half milliliter of the amount. And if you are using for more than 3 millimeter veins and using a 3% of the dose in a concentration, you use 1.2 to 2 milliliter in a total dose. So how do you measure it in relation to the body weight? If you are using a 0.5% in a patient of 50 kilograms, so we start with 20 milliliter as a whole dose per day. And as the body weight increases, you can increase the amount up to a 36 milliliter in a body weight of 90. And as the concentration goes up, we reduce the amount to reach 18 milliliter in 90 kilograms, 9 milliliter with 2%, 6 milliliter with 3%, in a total of 2 milligram per kg per day. So, what's your selection? What do you prefer? In 1 millimeter telangiectasia, 72% glycerin, or 0.25 STS, sodium tetraalkyl sulfate, or 0.5 polydecanol, or 11.7 hypertonic saline solution. 1 to 4 milliliter, we use either polydecanol or STS in a concentration of 0.5 to 1%. And in a large sized veins of 1 centimeter, we use STS in a foam form of 3% and polydecanol in 5% in a foam solution. So what our tips in sclerotherapy? Injection of the vessels in the minimally effective sclerosing concentration will avoid the risk of initiation of what we call telangiectatic matting, which means the development of a kind of blush of diffused colored, blue colored veins at the periphery of the injected area, which is a kind of upsetting for the patient, because they said, I got worse, I didn't get improved. But in the majority of the cases, as we will show later, most of this vanishes within 1 to 2 months without even any kind of intervention. So progression from the large vessels to the small vessels will avoid the kind of injecting the small vessels with extravasation. So we start with the large veins and it will flow into the smaller ones. The quantity of the solution to be injected is counting on the amount enough to ablate the blood inside the veins. And in my tricks, I usually inject air before injection of the solution. And the amount used to displace the whole blood away from the venous plexus is the amount I'm gonna use. And lastly, when you stop seeing the flow of the dye inside the veins, please stop sclerotherapy, because this means the flow goes inside the deep veins. Again, you start with compression, whether elastic compression or a kind of clip bandage, and this minimizes the inflammatory process and the formation of a thrombus, or we call it the coagulum. And again, sclerotherapy followed by bandage will minimize hyperpigmentation, cutaneous necrosis, telangiectatic matting, and in addition, it narrows the veins. Prevention of reflux inside the veins will minimize recanalization, and it will compress on the underlying perforators, and this will prevent recurrence. Again, lastly, it improves the function of the calf muscle pump. So the entire venous system should be treated at one time in one session, and the patient should be examined in 2 weeks. If you find a coagulum, please aspirate it with a large gauge needle to avoid the development of pigmentations. Again, microsclerotherapy, you can use a double or a 2-power loop and use a very small needle like 30 gauge needle, and use a combination of 72% glycerin mixed in 2:1 with 1% lidocaine and epinephrine. This minimizes the incidence of telangiectatic matting, pigmentation, and ulceration. You can use also the vein detector in your sclerotherapy. As you see, we start with the large venules, and then we further go inside the smaller veins. I start with injection of the air, and I displace all the column of blood inside. Stop sclerotherapy when you didn't find the flow of the sclerosant inside the vein. There is no limitation in the amount of the air you inject. It doesn't matter, because all this air will be absorbed soon before it goes anywhere in the pulmonary tree, because many of the people get afraid of that. And then you go again from the dark or the bluish veins into the smaller veins, and you start from above downward. You can have results like this, total vanishing with only sclerotherapy. You don't need to do any kind of laser ablation later on, total ablation before and after. So in many of the meta-analysis studies, they didn't find any difference, both photographically and clinically, between hypertonic cell solution and polydecanol. But polydecanol induces more telangiectatic matting and staining than hypertonic cell solution. Hypertonic is more painful, and hypertonic cell solution gives more patient satisfaction than the other kinds of sclerosants. The adverse sequelae of this is hyperpigmentation, telangiectatic matting, necrosis, and thrombophlebitis, in addition to inadvertent injection into sometimes, which I think it doesn't happen, into arteries and pulmonary embolism. Let's go through this. Pain, it is always minor pain unless you are injecting into outside the vein or extravasation has happened. And pain has been defined to be less with polydecanol than with hypertonic saline solution and STS. Telangiectatic matting means a coloration around. It happens in 24% of the cases, usually resolve in a couple of months, and telangiectatic matting is more with polydecanol. Hyperpigmentation, you can see on this area, I've tried to use foam sclerotherapy with polydecanol, and you can see hyperpigmentation on the right hand side, in addition to hypertonic solution in the lateral part, and you didn't find any hyperpigmentation with hypertonic cell solution, which is different from the polydecanol that induces a major hyperpigmentation due to extravasation of the RBCs and the hemosiderin deposition. And STS is associated, in addition to the hypertonic cell solution, with hyperpigmentation. Hypertonic cell solution has the least hyperpigmentation, and again, as you go higher with the dose, like 1% of polydecanol induces hyperpigmentation more than the 0.25. So if you have to use the polydecanol, use the minimal concentration to avoid hyperpigmentation. Skin ulceration, it is more with hypertonic cell solution and STS than the polydecanol. And something that is very impressive, that all sclerosants can induce anaphylaxis except hypertonic cell solution. So you can use whatever the amount and never be worried of the development of anaphylaxis or allergy of the patient. And does it induces any DVT? Theoretically, there is no kind of communication between telangiectasia and the deep veins. So there is no risk of DVT. Sclerotherapy can be optimized in this way. First, proper sclerosant, proper concentration, proper volume, injection of the proper site, which means the pigmented veins or the blue veins first before the telangiectatic veins. And how we deal through the Cochrane review, they found no difference in the satisfaction of the patient between different kinds of sclerosants, and no difference in the patient experience, yes, of 15 seconds. and no difference in the experience of the surgeon. So what do we need? We need a double-blind randomized study to compare the different sclerosants, but the challenge is that telangiectasia is treated in a private sessions for cosmetic purposes, so we cannot do this kind of double-blind randomized study. Thank you.